Okay.
Are we here?
Yes.
All righty. Hello, hello, everyone. Welcome, welcome, welcome. We're here again with OBHealthy and the Doctor's Lounge. And we're a group of doctors that come together every second Saturday for health and wellness, and two specific reasons. Number one, to improve the health of people of African descent. Number two is to encourage young black males to go into medicine because it is truly becoming something that is noticeable and something that we have to correct because we're finding that young black males are not going in the numbers that they were in the past, and we want to try to improve that. This webinar is every second Saturday at 1 o'clock. Alrighty, and it's so easy to join. Obviously, those that have joined already, and I'm sure others will be coming in as the hours go on. You just have to go to OB Healthy and click on the doctors tab. And once you do that, just sign in and you're a part of it. The most important thing is that you can type in your medical questions. So please do not hesitate to ask a question. It's so important that because we're here to answer your questions. You can view prior webinars by just going to our website and hitting the YouTube tab. All of our prior webinars are there. They're educational, they're informative. Please check them out. I would like to thank OB Healthy for allowing us to bring this webinar to you every month. And the most important thing that I can say, and I'll say it several times during the show, is please do not change any aspect of your medical care until you consult your physician. Only your private doctor, and that's true, only your private doctor can truly take care of you from a medical standpoint. All righty. I think I've covered everything. Doctors will be coming in. I've heard from several of them, and they are making rounds at the hospital. I know at least one or two of them are still in surgery, so but they will be coming in as the show goes on, and we'll be hitting this topic. Now, the topic that we have today is, um, hold on for, all righty, all right, reclaim. Okay, the topic that we have today is cardiothoracic surgery and the failing heart. And the person to talk about this. And he's someone that I've known since I've been practicing medicine, and I respect him so in his skill. And just to let you know how much I do respect him and understand what he does, if I need surgery, guess who I'm going to call? I'm going to call Dr. Karanam, Dr. Robbie Karanam. He's a good friend and he's an excellent surgeon, and he's here to let you know what cardiothoracic surgery is all about. Robbie, welcome to OB Healthy. Welcome to the Doctor's Lounge. I'm so happy that you took time, taken time to come and be a part of this show today. Thank you very much. What I'd like to do is just start off some basics. Why did you want to become a cardiothoracic surgery? And even better, how did you become a cardiothoracic surgeon? Just for the young people that may have that hankering to do what you do.
Thank you, Omar. Thank you. Um, I was born and brought up in India, went to medical school in India. The reason why I left India at that time is you read a lot of things in the book, but the resources weren't there to practice what you learn. So I said, I have to get some advanced training and came to United States. Did my general surgery training in New York. Somehow general surgery didn't tickle my enthusiasm because much of what I learned I was already doing in India. Okay. The one part I didn't do in India was opening the chest to do heart surgery and lung surgery. And although I initially came into United States to learn reconstructive plastic surgery, I was not terribly impressed with that at that time. And I happened to rotate in my surgical training through Westchester County Medical Center. There were three surgeons. For one reason or the other, all three of them were single. Okay. They would do heart surgery and
Mhm.
anything from neck down to the toes, if they needed an operation, they were perfectly capable of operating on them. All these operations, taking care of the patients, post op care, everything else. That really impressed me that this is like a command of your skills and knowledge. I'd like to go into this field. Those are the ones who actually uh, sort of mentors to go into this field. Then I applied. It was not easy to get into residency program during those days, and I got the offer at Newark Beth Israel, Newark,
Mhm,
1981.
mhm,
So that was a 3-year residency, tough residency, pyramid system. I don't know if the other viewers know what pyramid is. They take three and fire two and make one guy as the graduating resident. So I made it through that filter, and then the surgical group that was dominant at that place, they offered me an employment. So I stayed, and the employment led to practice. Practice led to, faculty practice. So for the 41 years or so, something like that, I've been at Beth doing heart surgery.
mhm, mhm.
Okay.
Excellent, excellent, excellent. You know, what a story. I'm going to tell you the truth. What a story. Tell me, Robbie, let's just step back for a minute. Just in your explaining, what is cardiothoracic surgery? I know what well, put it this way. Maybe I can explain it this way, and we'll get touch on this as well. What's a heart specialist or a cardiologist and a cardiothoracic surgeon? What is a cardiothoracic surgeon?
Okay. Thorax means it's chest, basically. That's the sort of Latin type of word, thorax. So anything that requires surgery in thorax is what cardiothoracic surgeons do.
Hmm.
Operate on the lungs, airways, esophagus, the gullet that goes in the back of the chest, heart, and great vessels that travel in the chest, and anything that relates to chest wall. All these operations are done by cardiothoracic surgeons. That is the training part of it. You get trained to learn how to manage all the surgical problems, operate on different structures from neck down to the diaphragm that separates the abdomen, belly, and the chest.
Hmm.
But
Hmm.
then what happens is, as time went on, the complexities of the operation, the progress in each field required more and more intense training in certain parts of the chest. So once you finish the training in cardiothoracic surgery, you differentiate yourself in doing either heart surgery alone, heart and great vessels, or the lungs and esophagus and all those things. So now that divides us into two groups, thoracic surgeons and cardiac surgeons. So even though I started off as a cardiothoracic surgeon, did everything for about 25 years,
Hmm.
the complexities of procedures and everything, I had to choose. So I went in the direction of cardiac surgery. That means I operate in the heart and great vessels in the chest.
Hmm. Hmm. Now, you said something. You called it thoracic surgery. A thoracic surgeon would just do the lungs or do that area around the lungs and explain that. Yeah, I understand.
Correct. Thoracic surgeons do everything in the chest except heart and great vessels.
Okay, okay. And when you say the great vessels, you mean like the aorta or that
Yeah.
big vessel that comes off the heart and supplies blood to the rest of the body? That's what you're talking about?
That's correct. That's correct. Yeah.
All right then. Now, give me. Let's just step back. Can you just give me an understanding of how the blood goes through the heart? Coming in from the veins and going through the all the other systems and coming out the other end. What
Yeah.
what what happens when the blood is coming up from the veins and doing its thing?
It's sort of very important that patients get the concept of what heart does. Heart is part of a, as we call, a system in the body called circulatory system.
Hmm.
That consists of heart, which is the central pump, arteries that go to the tissues and the entire organs and supply blood, and the veins that return after body extracts the oxygen and nutrients. The veins return the blood back to the heart, and the heart again oxygenates by pumping blood into the lungs and then pumps again into the entire body. So it's a one-way traffic throughout, and a heart is a central pump that pumps 70 to 110 minute per minute beats to keep on keeping that circulation going. Okay.
Hmm.
So, in order to maintain this one-way traffic, heart is built like two serial pumps, the
Right.
right side and the left side. The right side upper chamber receives the blood that has had its oxygen and nutrients extracted, and
Mm-hmm.
that upper chamber drops the blood into the right lower chamber.
Mm-hmm.
Right lower chamber pumps the blood into the lungs, where in
Mm-hmm.
the lungs, the blood gets cleaned up. As a matter of statement, carbon dioxide gets removed and oxygen gets added. That
Mm-hmm.
oxygenated blood returns to the left upper chamber. Left upper chamber drops blood into the left lower chamber, which is the strongest chamber of the heart. That pumps blood into the entire body through this big tube that's called aorta.
Mm-hmm.
And that, as it goes on, gives off branches to different organs, feeding every organ in the body. And once the organs extract the nutrients and oxygen, the small veins combine together and become larger and larger veins and bring the blood back to the right upper chamber again. This repeats 70 to 110 minutes, 110 times per minute throughout your life. Obviously, heart cannot take rest. So it's a very smart organ in some ways and a pretty dumb organ in some ways. It is a very smart organ because it can't rest. What it does is it feeds itself first before feeding the rest of the body.
Mm-hmm.
Dumb because all it does is pumps. It
Mm-hmm.
doesn't do. There is no tremendous intelligence there. Whatever it gets, it pumps out.
Alrighty.
Valves make sure that the blood goes one way. They're like the
Mm-hmm.
doors in between the chambers that will not allow the blood to go backwards. It only has to go forwards.
Mm-hmm. Alrighty. Um. Oh, Ken, were you saying something? You were on mute.
You're on mute.
You were on mute, Ken.
I
There
said
you
I'm
go.
okay. Someone was knocking on the door.
Oh, okay. Alrighty. The thing of it is that Robbie, you just said something that's so interesting. Is you said the heart feeds itself first. What do you
Yes.
mean by that?
When the left lower chamber, called left ventricle, pumps the blood,
Mm-hmm.
the valve between that and the aorta, the main tube that comes out of the heart, opens up.
Mm-hmm.
Blood goes through the aorta to the rest of the body. As the left lower chamber empties out, the valve shuts.
Mm-hmm.
So nothing leaks back.
Right.
But there's a segment of the aorta which is upright. So that column of blood can go forward now. It feeds two arteries that feed the heart. So the
Mm.
first two arteries that feed any organ are called coronary arteries that they feed the heart. So heart makes sure that it gets the food first, food and oxygen first.
Mm. Hmm. Yeah, yeah, that's so interesting. So when what's called the left ventricle, and that's the power part of the heart, that big muscle part of the heart that pushes blood out into the body, all right, into the aorta. There's an area there that has that when it comes on, when the aorta comes off the heart, there's an area there that has another artery that feeds blood back to the heart and around the heart so that the heart gets gets that oxygenated blood as well. Am
Yeah,
I correct there?
yeah, yeah.
Oh my goodness. All righty, all righty. You know one thing also, you were talking about how the heart beats continuously and it's the only muscle that never rests.
That's
It's
correct.
interesting. And just under my understanding is that a small heart usually is a strong heart and a large heart can be a weak heart, and that's opposite of other muscles in our bodies.
You're
The
right. For the
the
most, go ahead.
go ahead. You do. I don't want to take over. You go ahead.
For the most part, that is correct.
Mm-hmm.
Heart gets bigger, it's because heart is getting weaker.
Mm-hmm.
Heart is smaller, it's strong, it can pump the blood, it can increase the rate of pumping, how many beats per minute, all these things can accommodate.
Mm-hmm.
Except in some unique conditions, what's called a diastolic dysfunction, where the heart muscle gets so strong that the cavity gets too small. So it cannot relax. As much as squeezing the blood out is important, it's also important that after it squeezes the blood out, it has to relax and create enough space for the new aliquot of blood to come in.
Mm-hmm.
If it cannot relax, that heart is also sick heart. That's called the diastolic failure. When the hearts are bigger and weak, that's called a systolic failure.
Mm-hmm. 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 Oh, excellent, excellent, Robbie. And you know what I'm going to do? I was trying to wait till some of the other docs come in to introduce ourselves, but I feel that I should at this particular point. Dr. Court, welcome. Can you speak and let us know that your mic is working?
Dr. Cord, I
Mm-hmm.
practice in East Orange, New Jersey, and I'm
Mm-hmm.
among those great doctors who practice at Newark Bethesda Medical Center.
All
I
right.
remember I came, I think, 1 year before Dr. Karen
He
to
has to
Bethesda.
claim the seniority all the
Yes,
time.
sir. Yes, sir. Yes, sir.
Good afternoon, sir.
All
All
right.
right.
And Kendall, we didn't introduce you. Please introduce yourself.
Yeah, I'm Kendall Sprott, retired pediatrician. I did critical care pediatrics for 15 years and general pediatrics and administrative pediatrics thereafter.
All right. Thank you. Thank you. And of course, I'm Omar Bey, um, retired pulmonary critical care doc, and now I sort of dibble in nutrition, as I could say. Um, Dr. Karen Am, the thing of it is that I just like to know when you see a patient in the office, how do they come to you? How do they present to you? I mean, why would somebody come to you and need cardiac thoracic surgery?
Okay, since I have now sort of super specialized and limited to heart surgery, I can tell you how the heart surgery patients come to me.
Hmm.
They generally, there are two ways. Somebody comes to the emergency room, obviously they're in serious trouble and they call, ER physician sees them, the cardiologists get called, they evaluate the patient. If they find that the person has an illness that requires urgent or emergency surgery, then I get called. But that's
Hmm.
not the principal route. Principal route is internists are taking care of the patients. They begin to find that somebody has a heart disease, which could be the commonest one, of course, is coronary artery disease, which is the arteries that feed the heart have developed blockages, so the heart is not getting enough blood. So literally, heart is crying for blood. That's what causes them get chest discomfort, shortness of breath, fatigue, and all these things.
Hmm.
They get then referred to a general cardiologist. They examine them, get basic tests, which usually electrocardiogram, uh, echocardiogram, stress test, all these things. And if they are convinced that there is a problem, then they send it to an invasive cardiologist who then do invasive procedure, basically a diagnostic procedure where they do catheterization to see if there are changes in the coronary arteries blockages that require surgery, or can they do something about it, such as putting a stent and all that? Or do they
Hmm.
have pressures increased in the heart, either because one of the valves is narrowed or leaking quite a bit, or on occasion, is there a problem with the electrical system of the heart, conduction system? Well, for quite some time, I used to deal with the electrical system also. Now, the electrophysiologists, a group of cardiologists, they're specialists in that. They do a lot more complex procedures to manage them. So I've given up that also. It's not as simple as it used to be. So I take care of hearts that have inadequate blood supply for them to do the work that they need to do, or the valves that are damaged, either leaking or narrowed, or if a heart attack in the past has rendered the heart, a part of the heart weak, what
Hmm.
we call an aneurysm. If you cut that out and repair it, heart functions much better. And the aorta, the main aorta, sometimes it becomes enlarged. When they get to a certain size, there's a risk of them rupturing and causing sudden death. So that those are the group of patients I take care of. So
Hmm.
before I see patients have seen an internist, a, a general cardiologist, invasive cardiologist, often an interventional cardiologist. There are four or five filters before they come to me.
Hmm. Hmm. Yeah, interesting. Let's go back and I'm going to ask you to indulge. I mean, and to work with me here too, because you said a lot, and some of the things that I think you went through were just a little more technical, and I would like to break it down just a little bit, if possible.
Sure thing.
Um, when you said an echocardiogram, okay, and I understand that we're stepping back and talking probably about more a little bit about what cardiologists do as opposed to a cardiothoracic surgeon, but I think people need to know what the kind of the steps are as far as the echocardiogram, the EKG, those type of things. Those are basic things, but do people really understand what they are? Can you just and just in a few words,
The
like what is an EKG? What is an
uh,
echocardiogram?
electrocardiogram (EKG) is basically recording the electrical activity of the heart.
Mm-hmm.
Heart uh, has a spontaneous rhythm. That means it generates its own rhythm to beat regularly. In
Mm-hmm.
order to do that, there is electrical system built into the heart where upper chamber beats first, lower chambers beat next. So this
Mm-hmm.
goes on. And while that is happening, there is some electrical activity that is recordable. When you record that electrical activity with the leads placed on arms, chest, and all that, and you can tell based on if there's any injury or inadequate uh, electricity someplace, that tells you that there may be a problem in this particular area.
Mm-hmm.
So they do the electrocardiogram almost as a basic test.
Right.
After exam, taking the history, doing a physical examination, they check the blood pressure and pulse, and they you can make a lot of diagnosis by checking the blood pressure and pulse itself. But the electrocardiogram tells you how the heart is doing by the electrical activity. And then they do an echocardiogram, often in the doctor's offices. This is basically sound waves that are
Mm-hmm.
sent into the heart, towards the heart. We call it ultrasound because it's below the area where humans can hear.
Mm-hmm.
Okay, so
Mm-hmm.
those sounds they send it, they reflect off the heart, and the device records that and converts into a picture
Mm-hmm.
that tells you, is the chamber beating normally? Is there any area that is weak? Are the valves beating, opening and closing? Okay. How much leak is there? What is the difference of pressure between one chamber to the other? Is it within the normal range or beyond? So it gives a lot of information. Over the last several years, echocardiogram has become so sophisticated now, you can
Mm-hmm.
literally see every part of it in a picture fashion, three-dimensional echocardiography. It gives you beautiful pictures. You can analyze a lot of things. And
Mm-hmm.
in fact, in children, this is the dominant way most of the diagnoses are made. In adults, of course, putting a catheter and taking pictures is less risky, so we do that a little more rarely. But this echocardiogram is a phenomenal modality. It is non-invasive. It doesn't hurt you in any way. It's just a probe they put on the chest, and they take pictures. On
Mm-hmm.
occasion, they recommend doing a different kind of echocardiogram where they put a probe with you sedated through into your mouth, into your gullet, and take pictures from behind the heart. The advantage of that is it gives you much better, clear definition of the structural defects and all that. So it is more, uh, it's a little bit invasive because something has to be gone into the mouth and the esophagus, but it
Mm-hmm.
gives much better pictures. So
Mm-hmm.
those are the two modalities of ultrasound we do.
Excellent. Excellent. You said something about a catheterization, a cardiac catheterization, and putting stents in.
Yes.
When you say a stent, what is a stent? Is it putting a wire in, or is it putting a rubber piece in, or what are you putting in there?
It's a, when the cardiologist sends the patient to, let's say they do the diagnosis,
Mm-hmm.
when they make a diagnosis that a part of the heart is not moving as normally as it should move,
Right.
maybe there is probably inadequate blood supply to that area, which means the part of the artery that supplies blood is blocked. So they send it to the in, invasive cardiologist who now puts a catheter, nowadays for the most part through the wrist, on occasion through the groin, uh, in the past, we used to mostly do it to the groin. Now, majority of those catheterization can be done to the wrist.
Mm.
They pass the catheter under X-ray guidance into the heart and take pictures of these arteries that feed the heart.
Right.
That tells us if there is an area where that is blocked. Now, certain areas of blockage cannot be dealt with stents. If the
Mm-hmm.
main artery itself is blocked, the safest thing for them would be an operation. On
Right.
the other hand, somewhere downstream, like the artery in the front of the heart has got a blockage, then the cardiologist can pass a wire across all the way across that blockage and then bring what a balloon that stretches that blocked area to open it up. But in order to keep that opened area remain like that, they pass a there are a variety of stents, you know,
Mm-hmm.
metal piece that is crimped. They bring it up there and stretch that out to hold that in place with the blockage open.
Right.
The good thing about it is these days most of these stents now are what called a drug eluting stents. So they have drugs incorporated in them that prevents any scar formation. So they stay open. But the
Mm-hmm.
downside is, in order for those things to work, the patient must take blood thinners for the rest of their life, pills.
Mm-hmm. Right. Right. So they have to take pills that would prevent clotting.
Yes.
Okay. Mm-hmm. Mm-hmm.
Mainly aspirin and Plavix, they're not really complicated pills. They
Mm-hmm.
keep the blood thin. That's what they do.
Okay. Alrighty. Mm-hmm. Robbie, I understand you talked about valves,
Yeah.
the heart having valves,
Yeah.
um, and that these valves should open and close. What happens when they don't open and close properly, and how do we handle that?
Well, if they don't open, that's called stenosis, blockage. They also block, now the blood cannot go to the next chamber.
Right.
So pressure builds up and the back chamber begins to get bigger and bigger and fails, sometimes leading to irregular hearts. And that back pressure can uh, cause congestion in the liver, kidneys, leg swelling, and all these things. That's what we call a congestive heart failure.
Mm-hmm.
Okay. On the other hand, if they leak, each time the pumping chamber of the heart has to pump blood, it pumps, half of it leaks back, but the body's needs don't decrease. So next time around, it wants more blood. So with each beat, it recruits more and more blood to pump forward, so enough blood goes to the body. In the
Mm-hmm.
process, it gets bigger and bigger and bigger. After a certain size, it cannot shrink anymore. Then they
Right.
get again a congestive heart failure. So
Mm.
both the leak and narrowing are bad. So valves need to open perfectly and close perfectly. And if they're not doing, there are multiple ways of managing them. When they're minimal, we can manage them with medications and all that.
Mm-hmm.
They're in between. Sometimes we can open up with a balloon without cutting open the chest. But if they're
Mm-hmm.
really badly deformed, then surgeons like me open the chest, either repair them or replace them with the man-made valves.
Hmm. Hmm. Interesting. So you actually can put a new valve in there
That's
and
correct.
allow that valve to open and close properly going forward.
That's correct.
Alrighty. Now, when you do cardiothoracic surgery, I know that's in the ICU and all of this kind of stuff. Um, how long? Well, let's step back. I'm ahead of myself again. Alrighty. Um, you know, taking someone into surgery. I mean, what happens? I mean, we talk about heart surgery, but there's a lot that happens in the surgical
Yeah.
area while
Yeah.
you're doing this.
Yes.
H- how do you do what you do, and what type of team do you need to get this done?
Yeah. It's a. This is why it's a bit controlled in most states. The state has to give you uh, a certificate which
Hmm.
states basically there's a need for it and there
Hmm.
are resources, there's commitment. Unless you have that, you don't get what's called a certificate of need. Anyway, the once we make a decision, I see the patient and let's take the uh, one valve, the valve that's between left upper and left lower chamber. Okay,
Hmm.
mitral valve. It's called a mitral valve because it looks like Pope's hat. Okay, uh, so a mitral valve, let's assume is leaking quite a bit. That's
Mm-hmm.
one possibility. If it's leaking, then we tell them that you reached a point that we need to fix it, and we'll try to repair it.
Mm-hmm.
Generally, mitral valve that's leaking, 80 to 90% of them can actually be repaired.
Mm.
On the other hand, if there's a rheumatic valvular disease or the valve that with a lot of calcium built up and all that, then we'll have to remove it and put a new valve in. So we do a battery of tests before we uh, embark on the operation, just to make sure the operation uh, doesn't become unsafe due to other incidental problems in the body. Assuming all that clears, a patient doesn't eat or drink past the midnight. Generally, we would like them to come from home. It is not good to be in the hospital before surgery if you can avoid it. We take them to the operating room, and the anesthesiologists who are specialized in giving anesthesia for heart surgery only are the ones who work with us. They start a IV in the arm and a second line that monitors the pressure, giving local anesthesia. After that, patient will not know anything. After that, they put him to sleep. Everything else is done afterwards. We put in multiple monitoring lines. We want to make sure we know how much urine output is coming out per hour. We want to know what is the pressure on the left side of the chambers, right side of the chambers, how much is heart pumping while we are still preparing to do the actual part of the operation.
Mm-hmm.
All these things have to be monitored, maintained properly. So we put all these lines, and then from neck down to the toes, we prep the patient with the antiseptic solution, and we work as a team. It's a fairly large team. There's usually anesthesiologist and assistant to anesthesia, a, a one or two assistants to the surgeon, scrub nurse who actually hands over the instruments as we are operating. They know exactly what instruments to hand over, so we don't
Mm-hmm.
have to constantly explain what I need. So they're
Mm-hmm.
well trained in that. And there's what's called a circulating nurse. Anything that is not there, the circulating nurse will run and get it.
Mm-hmm.
And there are two people behind me who are called perfusionists, the primary perfusionist and the secondary perfusionist. They run the heart lung machine. What the heart lung machine does is when I actually do the principal part of the operation, I'll have to stop the heart for majority of the operations.
Well, you stop the heart.
Yeah, we have to stop the heart and the lungs. During that
Okay.
time, this machine provides the required blood and oxygen for the entire body.
Mm-hmm.
So that
Mm-hmm.
is run by perfusionists. They are trained specially to do that. They
Mm-hmm.
usually two of them. So it's a huge team working there. Although I may be the captain of the ship, but any one of them doesn't do their job, patient will not have a good outcome. So uh, and then we open the chest. There are varieties of ways of opening the chest depending on what you need to do, but commonest way is we split the breastbone in the middle and then give some blood thinners to the patient. So the blood is really thin, it does not clot. Put some
Mm-hmm.
tubes inside the heart. Those tubes get connected to the heart lung machine, and we divert the circulation onto the heart lung machine and confirm that the perfusionist, the guy who's running that machine, tells me that he's able to run as much blood as body needs. Then we can stop the heart and lungs. And with the heart sitting quietly, we can do whatever needs to be done, either bypasses, valve repair, valve replacement. When all that is done, we restart the heart. During
Mm-hmm.
this time, we bring the patient's body temperature to a lower degree to decrease the demands of oxygen and nutrition for the rest of the body during that time.
Mm.
And then we restart the heart. As the heart starts beating, pumping strong, we separate from the heart lung machine, take all the tubes out, and we have a different medicine that we give to reverse the medicine that caused their blood to become thin. And then control any bleeding, put some drainage tubes, stitch them back together. It usually takes about 4 or 5 hours or so.
Mm-hmm. Mm-hmm.
And
Now,
then,
I got a couple questions, right?
yeah, yes, yes, go on.
Now, when you said you stop the heart, I can understand stopping the heart. But how do you restart the heart? What is this? Jumping cables? Tell me what's going on.
Uh, we- what happens is, we talked earlier on, the heart gets fed by the two arteries that come out of the aorta. Remember?
Mm-hmm. Mm-hmm.
Okay. We clamp off the aorta beyond them. So now heart is isolated from the rest of the body, literally. Okay.
Mm-hmm.
Into that little chamber where those arteries feed the heart, we
Mm-hmm.
give a special concoction of medicine that has variety of things that are added, but the principal component is it is cold and it has potassium.
Mm.
When we increase the potassium of the heart to a level, heart doesn't beat. And once the work is done, we release the clamp. Now the normal blood starts feeding the heart, automatically washes out what we gave, and the heart begins to beat. Because heart is not lazy; it works all the time. It wants to work.
Mm.
So you just have to feed the heart. That's all.
That's all you have to do is just give
Yeah,
it oxygen and
yeah,
take the potassium level
yeah,
down.
yeah, yeah.
That is that, you taught me something, Robbie. That I did not know. I did not know. Excellent, excellent. Um, Dr. Atherley just came in.
Hello.
Hello there.
Good
Good
afternoon,
afternoon,
everyone.
Atherley.
Pleasure to be with you as usual, and great to see my old colleague, Dr. Karnam,
Pleasure.
excellent
Pleasure.
surgeon, and I'm very pleased to hear his discourse here. Hi,
Yes,
Robbie.
yes,
Hello. Hello.
sir.
Hello.
Yes, yes.
I'm
Uh,
sure Robbie has the talent and ability to make a very, very difficult procedure sound simple. It
mm-hmm,
requires an extremely great amount of training and continued skill to be able to perform these procedures and to perform them safely and with good results. And that's what he's been doing over the years, over the many years that we've known him.
mm.
Good.
Yes, yes. We appreciate him at Beth Israel. 110%. Yes, yes, yes. Um, Dr. Karen M., I think you may have stated, but how long does the surgery usually take? And the second question would be, how long is the heart, not functioning, stopped during the procedure?
Omar, depends on what you have to do. If you need to do a couple of bypasses, it doesn't take too long. On a
Bypasses. What's a bypass?
that's
I know I'm stopping you, but I
when
understand what you're talking about. But the
when there's a
common.
blocked artery that feeds the heart,
Mm-hmm,
need to give a heart attack, we use a separate conduit as a new pipe. One end connects to the aorta, where his blood comes back to the heart, and the other end onto the artery beyond the blockage. Since we're
mm-hmm,
bypassing the blockage, we call it bypass. We
mm-hmm,
use either the veins from the leg or the arteries behind the breastbone or artery from the forearm. Basically, a spare part. We take it and let the blood now flow beyond the blockage. So it's called a bypass. So that is the commonest adult heart surgery done in the country, and
mm-hmm,
by most surgeons' opinion, the most difficult operation. Although people don't feel it that way because it's done quite often.
mm-hmm, mm-hmm, mm-hmm.
It's
So
a
you actually take blood vessels from other parts of the body, and then you place them in the heart so that that the blood can go past that blockage.
That's correct. That's correct.
Okay. Mm-hmm, mm-hmm. Oh, interesting.
For
Interesting.
the listeners, if they're going for a bypass surgery someplace, you need to insist on them getting the surgeon using the artery behind the breastbone. That is
Mm,
by far the best bypass, known to last 95% of the time, 25 years.
mm-hmm,
So
mm-hmm,
uh, you should do all possible efforts to make sure you use that.
mm-hmm. Excellent. Excellent. Do you, when you're evaluating a patient to go under uh, this massive surgery that we're talking about here, because it's significant, and believe me, I understand the complexities of it. Do you think about risk factors? Like high blood pressure, diabetes, the high cholesterol, whether they smoked, or whether they, what condition that person is as far as health is concerned, and the likelihood that you can get them through all of this.
Yes, you're absolutely right. The risk factors are very important. Uh, Newark Baptist actually started the risk stratification before anybody in the world did. Okay, that came from Newark Beth Israel. Later on, other organizations adopted in a simplistic way so it is usable. So
Mhm,
we put in all these risk factors into a formula and sort of predict the risk of death and major complications based on that. As you said, obesity is a risk factor.
Mm-hmm.
Diabetes is a risk factor. High blood pressure is a risk factor. How good is the heart is a risk factor.
Mm-hmm.
Uh, Almost every metabolic condition is a risk factor. Smoking, definitely. Smoking before is bad. If you smoke after the bypass, grafts close also. So it's bad after that also. Um, all these things we take into consideration and sort of predict what is likely risk in a given patient and actually explain that to the patient and family. What is the risk of death? What is the risk of major complications in a given patient?
Mm-hmm.
Despite all our best efforts, there is a finite risk in this one. How do we promote the operation? Because without it, the risk is inordinately higher if the person gets, for example, a heart attack. Each heart
Mm-hmm.
attack that happens outside, unmonitored, has a 50% chance of dying. If he's somewhere in the hospital under people's observation, there's a 30% chance of dying. And if you survive, you're significantly compromised. You can't breathe, you can't do anything. So when you compare that to the surgery, uh, we can say, okay, it's worth it, but it's not without its risk.
All righty. I want to ask now because it's just fascinating to me. Um, at are there patients that come to you that you say, the risk is just too high, I can't do this?
That's correct. Yes, we do. We turn them down because the benefit does not justify based on the risk.
Mm-hmm.
So some things that patients can do is obviously correcting some of the risk factors, which
Mm-hmm.
is, for example, someone is going for an elective heart surgery. That means we can schedule it 4 weeks down the line. There's plenty evidence if you stop smoking
Hmm.
for a few weeks, it improves the wound healing and decreases the risk of infections.
Interesting.
Two, if you can stay active as possible, and then
Mm-hmm.
come in the morning of surgery, it decreases the risk of infections. So there are
Mm-hmm.
things patients can do also. Okay.
Right.
Emergency surgery is always bad, and some of these habits like smoking, alcohol, and all that prior to surgery are bad because we stress the body's organs, and it's better that they're in the best shape possible to take the stress.
Mm-hmm. Mm-hmm. Yeah. 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 I am. I'm just interesting because in what you're talking about at this particular point, I gather there are certain patients that actually come under the guidelines of a heart transplant. But even with that, you still have to have, I guess, a secondary. Your body still has to be strong enough so that you can get through it. You understand what I'm saying?
Yeah, yeah. So
Mm,
if somebody, let's assume, is sent to me with a advanced heart failure who I think is unlikely to benefit from a traditional valve surgery or whatever,
mm-hmm,
so then we try to send them to a group of cardiologists who are experts in managing heart failure, which means heart is unable to pump properly.
mm-hmm,
So they try to evaluate them on all multiple aspects of it and then try to see if they can medically manage them, maximize how the heart can support the human body
mm-hmm,
without major operations. And if that is not an option, then we have next options are putting either a device in them called
mm,
assist device or evaluate them for a heart transplantation when you replace their heart with someone else who passed away, their heart. So
mm-hmm,
those are the two extreme modalities that you use when traditional operations or a medical therapy is exhausted.
mm-hmm, mm-hmm. Dr. Atherley, you have your hand up.
Well, I just wanted to ask Ravi a very basic question that has troubled us, of course.
Mm-hmm,
There are many patients who are somewhat concerned, as they well should be, and scared of having open heart surgery. It sounds like a very big thing.
mm-hmm,
And while that was the only option many years ago for many of the kind of problems that cause heart attacks, for example, blockage of the arteries, etc., nowadays there are several other options that have sort of encroached upon the domain of the thoracic surgeon. So I want to ask Ravi his opinion of what sort of Under what circumstances are we faced with advising the patient that this is a little beyond the reach of the cardiologist, the so-called interventional cardiologist, cannot just go in and fix this with catheters, with tubes and wires and little balloons and all that, but you do need open heart surgery. How difficult is that a decision to make for the average patient who's confronted with these choices?
Yeah, as a matter of fact, last week I had a patient who said, "Why can't I get a stent?" I had to just draw the picture and show him it's the blockages at the bifurcation of the left main artery, the main artery that comes provides blood to the left side of the heart, involving both the artery in the front and the back. And he's a relatively young person in good health. So I
Hmm.
said, if they try to put a stent, there's a good possibility if you try to open one, the other one closes, or if they put two stents kissing each other, the long-term patency may not be as great. On the other hand, at your age, if I put one bypass in the front and send you home, let's assume I don't do the whole thing, that artery can keep you alive 25 years. And it's not a good idea to go for the stents. In fact, the doctor who does the stents has sent the patient to me. So that tells you that he feels that that's not the right advice.
Hmm. Hmm.
But as an extension of your question, Dr. Atherley, but there are some procedures that we used to decline doing on elderly patients in the past. Now we have modalities where we can provide relief for them by doing interventional procedure rather than open heart surgery. Uh, One of them is what's called a TAVR. We're doing hundreds and hundreds of them. People in the 80s and 90s, they come in, we put a new valve in, they go home next day. As long as they're alive, they at least have good quality of life. Yes, there is a substantial progress in valve treatment, coronary treatment on the interventional cardiology and structural cardiology fields, but some patients are unsuitable and it's not best in their in best interest of them to do those procedures. We should still operate on them.
Yeah. Dr. Karen, can you explain, the TAVR? Because it's kind of, that word is kind of thrown around. I hear it all the time now, but I don't think people really understand that, exactly what you guys are doing when you manipulate that aortic valve in the way you do.
When the patient comes to Dr. Atherley, he monitors their aortic stenosis. The aortic valve is narrowed,
Mm-hmm.
monitor until a point where now there's a risk of heart failure, sudden death, heart attack, and all these things happening. So that's when they used to refer the patients to the surgeons to go and replace the valve.
Mm-hmm.
That's well and good. If you're 60 years of age, we can do the operation safely, and majority of the times, with almost a 98% chance, patient can safely be recovered and sent home. But when they begin to reach the 80s, this operation is extremely big and stressing for them. Their outcomes were not as good as younger people. In
Mm-hmm.
fact, that is a while ago, we published the paper, I think. If you took all the people over 80 years of age, their risk of death was, almost 10 times higher
Mm-hmm.
than the baseline. Fortunately, this new modality that came up, it can be done with a negligible risk almost. This is a valve that can be crimped and loaded on the catheter and take it most 95% of times to the groin artery, position it in the middle of patient's own aortic valve, and during a short duration of making the heart beat faster, we blow up the balloon and the valve opens up, anchors the patient's own valve. We take this catheter out. Generally, next day they can go home. They feel a whole lot better within several hours.
Mm-hmm.
So that procedure is caught on and is done in hundreds of thousands of times all over the world now.
I think this is one of the advances in cardiac surgery that's helping so many people, and it's a fairly simple procedure compared to open heart surgery.
Yeah, mind you, it's done as a heart team with the cardiologist. This is not done with independent surgeon's decision, because there's always a human bias could play, you know, a role in decision making. By
Mm-hmm.
having a contesting person on the other side, we decide which one is better, surgery or, you know, TAVR. And then if when you agree, we do it together.
Mm-hmm. Mm-hmm.
Because on occasion, the patient falls smack in the middle, and the patient generally prefers a TAVR, not surgery,
Yeah.
for obvious reasons. And, and in an unusual case of a complication in the operating room, in the last 5 years, I had to do that twice. We do about 250 to 300 cases per year,
Mm-hmm.
TAVRs. So you're talking about 2 out of 1,500 cases
Mm-hmm.
to do immediately heart surgery on them. So that's why the surgeons are involved in that as a team member. We do it as a team, and we've had excellent results doing that.
Mm-hmm. Mm-hmm. Excellent. Dr. Sprout, you have your hand up, please.
Yeah, I was gonna touch on what was just being discussed. In the old days when, I was in critical care pediatrics, we had cardiothoracic cases, and there were these conferences that were held that had sort of everyone there, the cardiologists, the various kinds of cardiologists, the cardiothoracic surgeon, the anesthesiologist, the critical care folks. And they would have the discussion of the cases one by one with the various diagnostic things that had been done and a discussion, and then a decision was made about how to proceed with a lot of back and forth. Are those days still present? You still have these conferences that has all the disciplines there where people can go back and forth and have a discussion, as opposed to seeing one doctor having a recommendation, not necessarily having the other doctors present that might have different opinions.
At least TAVRs are done with a multidisciplinary conference. Usually there is a structural cardiologists and heart surgeons and the industry representatives. They also have an input, because they'll tell you this may not lodge well because they have massive amount of data. So with all those discussions with the physician assistants, there's usually about I don't know, 6 to 8 people on most of these meetings. There is a multidisciplinary conference on all towers to make a decision. Now,
Mm-hmm.
And
what's happening is, although I should, truth be said, as this procedure is becoming so common, some of the patients just don't require that much discussion. It's a pretty clear-cut indication one way or the other. But that still leaves us with a group of patients where we really seriously discuss, argue, express our opinions, and then come to a conclusion.
yeah.
I think
Part of
that.
the reason I asked the question is
Mm-hmm.
Trevor, who's an old friend. When I have friends that have these issues relative to their heart, I always call Trevor and ask him, because I've seen a couple of my friends now who've been partially through a diagnostic, not a complete diagnostic, and they're already being referred to a surgeon without necessarily having all the diagnostics being done or interpreted. And then very often what happens is, and again, this is not necessarily here, is that the physician that actually did it doesn't talk to the patient after the diagnostic. And sometimes it's several weeks or so where they're talking to an assistant, but not the actual doctor. And so the patient's kind of in limbo. And the question is, what's happened, as medicine has advanced, that physicians aren't talking to the patients after these things, and recommendations are being made without necessarily having a follow up. Can you help me understand how that's happening and why?
Trevor, you want to answer that?
Well, I don't think that is the recommended approach. I think that communication is paramount. It is very important for the physician, whether it be the cardiologist or the cardiac surgeon, to discuss the options, discuss the outcome expected with the patients for any of the procedures that are performed. Now, the interdisciplinary discussion is not as significant nowadays as it used to be. We've become much more standardized in terms of the rationale for doing A versus B, recommending surgery versus, some form of intervention by the cardiologist. And so we feel more comfortable in making those recommendations without the need, in most of these patients, without the need for the large conference. But despite that, there still is the need for the surgeon and the medical person, the cardiologist, to communicate, especially where there is some question, especially where some situations may be more severe and require that. But there is the need for continued communication, even if not in as formed a situation as they used to have in the old days of weekly conferences where every single patient intended for surgery would be presented to a whole team, etc. Nowadays, I think they're much more standardized, and we go one-on-one. The cardiologist may talk to the surgeon, or the surgeon to the cardiologist, and discuss. And if there still is some doubt, then getting putting a call through to a trusted colleague and getting a further opinion would be appropriate. But I think that
So,
communication with other individuals in similar disciplines, and most importantly, communication with the patient, these are all very, very important.
he Dr. Karanam spoke about people that used to attend these things having lots and lots of data. Do you envision artificial intelligence playing a role in looking at some of these risk factors and some of these results of some of these procedures, and AI coming up with a recommendation as to how they might proceed?
Do you want me to answer that
Anybody?
as the father of AI answered it? The guy is a Nobel laureate. He said 99% of the employment will be eliminated in this country and the world. And then he retracted probably 95%, not 99. Knowledge workers can all be replaced with AI, and simple technical workers can all be replaced with AI. Complex technical labor with a high risk of a price for error are the only ones who will remain doing what need to be done by the humans. So the prediction is much of the labor force will become unnecessary. So I don't think medicine is going to be an exception when it comes to that. You saw the Google laid off like 40,000 or so, and all these major corporations have laid off already as the AI penetrated their organizations. Uh, all major healthcare systems have already a division in their parent corporation totally dedicated to AI development. So it's coming. It is coming. It will happen.
Yeah, we can't stall progress, I suppose, and it would be expected progress to have AI make the decisions, the clinical decisions, and all that. But I agree with Ravi that those who require significant technical challenges, who have significant technical challenges, will have to have a surgeon who can think on the spot, who can change and do what is needed based upon what he sees at that particular time, rather merely from the planning beforehand. And there's one other arena in which I think AI will not ever replace us, and that is like in physicians like Dr. James Court, whose calm demeanor and discussion with the patient, I cannot envisage being replaced by a machine. So there still will be
No,
the
they
need
can't.
for such physicians.
Yeah, unless
Nope.
the insurance company says the machine can replace them.
Pardon?
No, they can't. They can't do that. No, I'm unique, so they can't do that.
You're unique.
Currently there is a robot nurse and nurse practitioner already in practice, where if Dr. Code is sitting there examining, taking the history and all that, as he's taking the history and examining, the robot is watching, creates a history and physical. With AI, creates a diagnosis, differential diagnosis, proposed plan of therapy. So the moment he finishes, there's a document for him to look at and see what patient needs, and he can correct it after that. So his
Mm.
life might become a lot simpler.
But the result that AI gives you, isn't it determined by what you put in to the system? And what we give them, that they come up with a result or a recommendation? They still need humans to think
No,
that.
the so-called mega data they've collected over
So,
several years from healthcare systems, data banks, and all that. And part of the problem is there is such a thing called machine learning. Each time it gets better and better, it learns. So a combination of machine learning and the big data is putting in so much knowledge. It's actually a lot harder for a human to have that much knowledge in the head. What is different is judgment comes in, and hallucinations are a problem with the AI. They hallucinate, and that's what we need to watch for.
Hmm. Dr. Court, did you have your hand up for a question?
Yes.
I was asking Dr. Karen, what would be a typical patient that you would need to operate on? What should the patient present with, and what should have been done before patient gets to you?
I always tell administrators and all that, even though I do these big operations, um, a dime spent uh, in Dr. Court's office rewards a lot more to humanity than what I do. No question. Preventive care, screening, advising patients, that goes a long way than the amount of money that gets spent on heart surgery is it's really not rewarding to the community, but for the individual it's very important. So that's number one. So I prefer, like, several times I get patients who are morbidly obese who have mitral valve disease or you know triple ulcer disease, for example. uh, if they could lose that weight, the outcome of the surgery will be much better.
Mm.
And if there's a mitral regurgitation, if they lose a substantial weight, I've seen at least a handful of patients, the regurgitation becomes a lot less and they don't need surgery. So preventive management by internists probably far outweighs what we provide in the community. But when they come to me, obviously that they've already passed that phase, then we have to do something. So ideal candidate for me would be probably in the 60s to early 70s with no comorbidities. Each comorbidity, diabetes, for example, coronary artery bypass, diabetes adds about half a percentage risk for death. Hypertension adds half a percentage. If you keep adding comorbidities, each one of them, an operation that can be done with a 1% risk of death will become 4 or 5%. That may not look bad, but it's 5 times more than the baseline. Okay. So there's a lot that can be done by the internists and primary cardiologists to manage them, uh, risk factors, and maybe bring them back to healthy zone, so to keep them away from me as much as possible.
Hmm. Hmm. Interesting. Yeah, risk factors. I think about them all the time as far as diabetes. I mean, we were just gotten back from the medical mission in Guyana with Dr. Court, and one of the things that I noted, and I'm sure this is worldwide, is that diabetes was so common, and the blood sugars coming in, and they were high, and hypertension, and it was just such a common risk factor that I think that being, doing a lot of nutrition now, it's really a focus for me to see if I can get the blood sugars down and get the, blood pressure down and things like that through their diets, and the improvement of health that comes about just because of that. And you're right, Robbie. What I'd like to do, it's our halftime. I'd like to do my spiel. We're going to try that. We're going to reintroduce each other, I mean ourselves, and then from there, there are a couple questions that have come through. I'd like to tackle those questions as well, and then we'll get back to just some basic general talking. Um, so first thing I'd like to do is I'd like to each and every one of us to reintroduce ourselves. Dr. Sprott, can you start us off, please?
Yeah, Kenny Sprott, retired pediatrician, did critical care pediatrics as well as general pediatrics and administrative pediatrics.
Okay. Dr. Karen, please.
Ravi Karanam, I'm a cardiothoracic surgeon and actively practicing at Newark, Beth Israel.
All righty. Dr. Court?
Dr. Gordon, I'm an internist. My office is in East Orange, New Jersey, and I practice at Newark Bethesda Medical Center with these guys.
All righty. And Dr. Atherley, please.
I'm Trevor Atherley. I'm an interventional cardiologist, and I practice at Newark Beth Israel Medical Center.
All righty. And I'm Dr. Omar Bey, retired pulmonary critical care doc, and just the host of this show, and just so happy that my colleagues could come in and be a part of this great discussion on heart failure and cardiothoracic surgery. Remember, every second Saturday, this webinar at 1 o'clock Eastern time. And I would just like everybody to understand that it takes a village. So tell somebody, you know what I mean? And let's just get as large an audience as possible, because health education is so important as far as long life and a healthy long life, not just a long life. The one thing I'd like to say is, please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you from a medical standpoint. As far as our past webinars, all you have to do is go to OBHealthy and the website. You can hit our YouTube button, or on the doctor's page, there's a little camera there. Just hit that, and all of our past webinars come up. Please take a look. And other than that, I'm just thankful that OBHealthy is allowing us to bring this webinar to you, the Doctor's Lounge, and we're going to continue. All right, we have a question, and I'd just like to let's see now. Let's see. Did someone answer the question? Answers, discuss. Oh, did I lose my question? Okay, let's try this one. What keeps the patient alive when the heart is shut down? That's one. Robbie?
Heart-lung machine. The machine
Go ahead. I'm going to let you explain this one because it gets a little complicated
put
sometimes.
tubes inside the heart with the patient's blood really thinned out, giving a blood thinner. We drain the blood from the right side of the heart into the machine. The machine oxygenates the blood and removes the carbon dioxide and pumps it back into the aorta, the main tube that comes out of the heart. That way, what heart does and what lungs do, that machine is doing while we're stopping the heart and lungs.
All righty. Excellent. There's another question here, and this is a good one. If an individual 64 years old with a history of 3 stents in one artery after surviving 2 heart attacks with no damage to the heart, only blockage in one artery, what is the longevity of 3 stents in that one artery to prevent subsequent heart attacks? Family history, coronary artery disease, congestive heart failure, high blood pressure on father's side of the family.
I think Trevor is the best person to answer that.
Well, it certainly is a question that can have multiple answers because we need a little bit more information from the individual. Now, the stents, when placed in the coronary arteries, are themselves subject to failing. And how does the stent fail? The stent may fail if a clot forms in the stent, and that can happen acutely. It can happen years later in what is called subacute stenosis, or it can happen if the lining of the heart starts to form and gradually narrow that stent. Now, a lot of the things that happen to the stents are the problems related to the stents themselves, but also to the coronary arteries. And so to answer a question as to how long a stent may last depends on, well, when the stent was placed and what kind of stent was placed. The newer stents last much longer, many more years than the older stents. The older stents that we used were not drug coated, for example, and were subject to being blocked themselves by new formation on the stents and with clots forming there within the stents. So the stents themselves have improved. Importantly, what has also happened is that the technique of placing these stents has also improved. And after the stents are placed, we even pass small devices, an ultrasonic device, to look inside the coronary artery and to be sure that the stent is well positioned, placed well against the wall of the artery, as opposed to being inadequately placed. So there are many, many factors that can determine how long these stents last. But I would say by and large, stents last for many years. Now, it is interesting that the individual mentioned, 64 years old, 3 stents in one artery and having had a heart attack with no damage. Well, generally, heart attacks do cause damage. One of the distinctions between a heart attack and what we call angina pectoris may be the presence of actual damage to the heart muscle. So he's, in a sense, being spared if there's no damage. The other concept is that we know that the disease process that causes these blockages of the arteries tends to affect multiple areas, tends to be diffuse. And at 64 years old, I'd be surprised if there was no other disease at all affecting the other arteries. And what I often have to answer to patients when they ask me these kind of questions about whether or not we're going to have to go back in and fix stents is to remind them that the artery which was subjected to having the stents placed can have other areas of blockage. If you put stents in the near the beginning of the artery or near the distant part of the artery, then other parts of that same artery may be subject to blockages which themselves require new stents as opposed to fixing the old stent. And in addition, we must always think of the other arteries to the heart, and that some of these which were not subject or which did not require stents initially may later require stents. You must understand that we do not stent all blockages. Generally, we quantify the severity of the blockage of that artery. We consider that if it reaches a certain extent, I mean more than 70%, for example, then it may so significantly impair the blood flow through that artery that it will require to have that area opened. And stenting, of course, is the way that we use most times. We put a balloon down there, and of course, we put the stent. So at the time that those three stents were placed, it is quite possible that the other arteries, the other major arteries and their branches may have had some degree of blockage, but not severe enough to require stents at that time. So if this individual patient should, in the future, have symptoms or findings which suggest some progression, then of course it would be important to look to see whether it is the stent, the three stents that have been placed before, or whether or not it is other areas in the same arteries or in other arteries which will require further intervention. So it can become quite complex in analyzing what happens in the longevity of the stents and of the individual. But I would suggest to the patient that this is best served by his observing himself for specific signs and symptoms, by correcting some of those risk factors which we've identified back and forth, and of course, having frequent enough checkups so that we can determine if things are happening to further block that stented part of the artery or if other areas are becoming worse. You see, one of the problems we have is that with stents in there and with that much work done, there may be progression and he may not have the symptoms to give him a warning of such progression. So it's very important for him to see his doctor or doctors at regular enough intervals so they can try to get in there before something severe happens in the region of those stents or in the other arteries.
Excellent, excellent, Dr. Atherley. Dr. Court, your hand was up, and then we're going to go to Dr. Sprott.
It was just to reiterate what Athley just mentioned in terms of reduction of the risk factors, especially cholesterol
Mm-hmm. Mm-hmm.
and blood sugar and hypertension. That's all.
Mm-hmm. All righty, excellent.
Omar,
Dr. Sprott, I'm sorry.
Yeah.
Go ahead. Go ahead, Ravi.
before the break, you talked about diabetes in other countries and all that. A historical fact, once upon a time, sugar was considered a spice. We used sparingly. And before the Industrial Revolution, the farming was not as extensive as now, and the grains were not available. So if you go back and look at the data, what's available, and diabetes was not a common disease then.
Mm-hmm.
It is extremely common all over the world because people eat a lot of grains and a lot of sugar.
Mm-hmm. Yes,
And it's
yes.
also somewhat less active because locomotion has become more automobile motion rather than walking.
Mm-hmm. Mm-hmm. True, 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 true. Our diet has changed. Yeah, that's like Dr. Aluya always states that, and he's one of our physicians. He's not here today, but he's from Nigeria, and he's like back in the '80s, diabetes was virtually non-existent in Nigeria.
Yeah.
And now, because of modernization and fast foods and everything, diabetes is rampant in Nigeria. So it's a change that's coming, and it's only growing larger. So we have to get prepared from a medical standpoint. Dr. Sprott, please.
Yeah. When Trevor was talking about stents and he talked about consideration of other coronary arteries, I know that there are occasions where the same kind of problems that exist with the coronary arteries can exist with some of the other arteries, mainly the carotid arteries, the arteries that go towards the brain. Is there any consideration of evaluating carotid arteries in individuals that have had coronary artery disease?
I can answer that. It's a routine prior to every open heart surgery. We get a routine carotid non-invasive studies, and about 90% of the time, either is not significant or it could be staged at a later date. But in a small percentage, maybe somewhere in the range of 5%, we actually combine the procedure at the same time. Yes, we do check for that.
So, so when you
What
said,
procedure do you do? The
yeah,
carotids.
Endarterectomy at the same time.
Right.
We do the endarterectomy. The
Oh,
reason
okay,
for
Robbie, can you explain what that is?
Carotids.
reason why
You went
we
right over my head, man. Go, tell me what that is.
reason why we check this is when they're on heart lung machine, the blood flow is continuous, not like the heart pumping, the pulse. It doesn't have a pulse.
Mhm,
And if you have a significant narrowing of the arteries that supply blood to the brain,
mhm,
during that phase, uh, they can clot, or when you're manipulating the heart and great vessels, if a small piece breaks loose and plugs up the artery that's already narrowed, you can get a massive stroke. In order to avoid that, if the blockage is significant, we combine that operation along with the heart operation. Basically, we make a cut in the neck over the artery that supplies blood to the brain and get control of the artery on either side, open, remove the plaque, and if
mhm,
necessary, patch it, enlarging the artery. That way, there is no narrowing in the artery that supplies blood to the brain. That's called carotid endarterectomy because we
mhm.
remove the inside of the artery. That's why called endarterectomy.
Excellent, excellent. Yeah, I think, yeah. Thank you for explaining that. Dr. Sprock, do you have you have your hand up?
yeah, just just a follow-up question to Trevor in terms of individuals that have had stents. You talked about follow-up. What's your recommended follow-up for individuals to get seen to evaluate to make sure that they're not having restenosis or things going on?
Well, the follow-up, of course, is with their physician or cardiologist. What the physician will do is, of course, check for symptoms. And the symptom that one would be most concerned about would be recurrence of the pain that brought them there in the first place, recurrence of the chest pain, angina pectoris, that is the kind of pain that we associate with narrowing of the coronary arteries. We look for limitation in physical capacity, which may be another consequence of the impaired blood supply and may even reflect silent damage that has happened to the heart muscle. So the symptoms are paramount, very important for the physician to check into those kind of symptoms, which we know can occur and suggest to us progression of the disease process that occurred previously. Then in terms of physical findings and testing, nowadays I find that, and Ravi, you also teach some of the young physicians that there's not as much emphasis on the physical findings and listening with the stethoscope as there used to be especially in coronary artery disease, in valvular heart disease. There may be more of that. But importantly, the reliance on certain tests. A simple electrocardiogram is important, and one should look at electrocardiograms routinely on these patients. They'll be seen at first after a few weeks to months, and then once or twice a year after that as they stabilize. But looking for changes on the electrocardiogram, which could indicate to us some changes in the blood flow to the heart, perhaps silent heart attacks or other problems such. And in the event that there are symptoms which require further objective evaluation, then the physician may decide, well, do I need an echocardiogram to look at the structure of the heart and the valves and to look at the function of the heart muscle? Or do I need a stress test to try to stimulate the patients, have them do exercise, for example? This was the simplest one. Do exercise and see whether or not with this exercise we bring about a disparity in the supply of the heart muscle and its needs, and see changes which may occur on the electrocardiogram during the time they're exercising. Or we look at the blood flow and we can use nuclear materials and do nuclear scans to see if the blood flow is impaired or affected by exercise, because sometimes blockages can occur and no particular signs or symptoms may be evident to the patient as they slowly progress and may not reach a level which is clearly one that might be associated with, as we said, the angina pectoris, etc. But these may be shown up on certain tests, so stress tests may be done. Now, we don't recommend necessarily doing routine stress tests, although there may be an argument for doing stress tests 2 years after open heart surgery for coronary artery disease or doing stents. But we rather do stress testing if there is something to indicate that there may be some progression and the need exists. So these are some of the tests and some of the observations that would be done on these patients by way of follow-up after stents have been placed. And of course, the more significant circumstance would be possibility of doing a cardiac catheterization if one had to look more closely. There are other non-invasive tests, but I wouldn't go into all those details at this time. But certainly a cardiac catheterization to look again more closely at the coronary arteries and to be able to fix them if the areas that were stented, etc., are showing need for further intervention, further stenting, ballooning, etc.
Mm-hmm. Excellent.
Or, of course, if you have to refer them to Dr. Carnam because the situation has progressed to such an extent that they do require full surgery.
Right. We have one of our physicians that joined us, Dr. Nelson Aluya. Please introduce yourself.
Yeah, good afternoon, everybody. Sorry I joined in late. Still trying to recuperate and catch up from my trip to Nigeria. So it's a pleasure to be here. Nelson Aluya, I'm medicine pediatrics trained. Currently the interim CMO for St. James Health. I run a private practice as well in Irvington, and as well as affiliated to the Newark Bethesda Medical Center. It's always a pleasure to be here, any day, anytime.
All right, thank you. And we're of course we're talking about heart surgery, cardiothoracic surgery, and the failing heart. So if you have any good questions or any thoughts, jump in there. Dr. Karen M, there's a question that came up, and there was a question that came about about the heart lung machine, I think, and I think this relates to that. It says that sounds like dialysis. Is it similar when you were doing when they said, how do you stop the heart doing surgery? I think that question came up earlier.
It's in some ways similar. It's basically dialysis machine takes a relatively small amount of blood out of the body continuously and cleans the blood of its metabolic end products, basically, for lack of a better word, and then infuses back into the patient. So that's trying to help the kidney function that is not working well to provide that kidneys function for the body. Heart lung machine is providing the heart's function. The amount of blood heart pumps is substantially higher, and kidney receives, I think, 20% of the cardiac output. So remaining 80% goes to the rest of the body. This machine has to supply blood to the entire body. So we drain a lot more blood at a rapid pace, add oxygen to that, pump it back. So it does the work of heart and lungs, even though it's a closed circuit similar to dialysis machine on a larger scale.
Excellent. Let me just take care of this last question, and then Dr. Sprout, I'm going to get to you. This is the same person that was the 64-year-old, and what they stated was currently on medications to keep the arteries open. Stents were placed in 2021 and 2022, Dr. Atherley. So is there any added information that you would want to say about that? Because as far as the stents are concerned,
nothing more that I can add with the information given. Actually, I still suggest to him that he maintain proper contact with his physician and have appropriate control of his risk factors, as we mentioned. Okay, but we can't predict how soon. I think he may have passed the worst of it for some kinds of stents in the first year or two, but after that, they expect it to last for many more years after that.
Right. Okay. Dr. Court, your hands up.
Dr. Trevor, what's the current recommendations in terms of the level that cholesterol should be?
Yeah. Well, the level of cholesterol is dependent on the person's underlying other factors. We like to look at multiplicity of risk factors and not merely at one. We looked at in the past at cholesterol, and we tried to give the patients an idea, in fact, that they should know their cholesterol. When I was involved, I was president of the American Heart Association for New Jersey. We had a statement that every single adult should know his or her cholesterol level. Now, I don't know if I went around the table and asked everyone if they knew their individual cholesterol levels, if everyone would tell me for sure. But in those days, it was much easier to look specifically at the cholesterol and say, well, a total cholesterol of less than 200, et cetera, et cetera. Nowadays, we define the level of cholesterol based upon other diseases. So that if, for example, you had heart attacks or previous evidence of significant involvement of the coronary arteries, or even of atherosclerotic disease, that's the kind of disease process in other arteries, then we would demand of you, or request of you gently, that you control your cholesterol, especially the bad cholesterol, the LDL, to less than 70. Some people nowadays are even going down to less than 50. But before, a level of 100 for the LDL, or the bad cholesterol, was considered the target. Then we lower that to 70, and there are some situations in which we try to lower it even more than that. We look more at the bad cholesterol, the LDL, although that may be counterbalanced by having a good number of the HDL, the level that you want of the HDL, which is protective. It helps to carry the bad cholesterol away from the coronary arteries to the liver to be cleared. So you want a significant elevation or a high number of the HDL and a low number of the bad, or the LDL, which is the one which is deposited within the coronary arteries and other vessels in the body and blocks them. So I'd say that if you've had no disease that is related to blockage of arteries anywhere in the body, and if you have no other risk factors, then I can accept an LDL or the bad level of 100. If you had any other disease process which we think is related to blockage of the coronary arteries, then 70 was the routine level that we aimed at before, that is of the LDL, or the bad low density lipoprotein cholesterol. However, nowadays we're even stricter in patients who've had defined coronary artery disease, and we're going down maybe to 50.
Mm-hmm. Excellent. Excellent.
If say the HDL is over 100, what should be your ideal LDL?
Tough question,
With no
because
other risk
even
factors.
though we mentioned counterbalancing, I think we still look at the LDL as a risk factor, even if you have some HDL which we think may be protective. I don't know what the exact number would be, and I'm not sure that there's any clearly defined information to say if your HDL is more than 100, which is a very high level of the good protective HDL, how much that can in fact counter the actual level of the LDL by way of quantification. You know, HDL such and such a level equals to such and such a risk, diminution. So it is very tough. I still advise patients, even if they got high HDLs, if the LDL is significantly elevated, I still recommend that they attempt to lower the LDL.
Correct.
Mm-hmm.
The bigger problem may be if the HDL is, in terms of treatment, if the HDL is low. I've had several patients who've had heart attacks and had blockage of the arteries, whose LDL, or the bad cholesterol, was not significantly elevated, but they also had very low levels of the HDL, or the good protective cholesterol. So there's nothing much that we have to increase the amount of HDL, unfortunately.
Mm-hmm. Mm-hmm. Excellent. Excellent.
Does the exercise increase the HDL that rapidly?
To some extent, although I don't know that the measurable amount, the exercise and things like cessation of smoking, minimizing the amount of alcohol use, these all seem to have a beneficial effect on the balance overall, and especially on the cholesterol, not especially, but including. I should have added that, remember we're talking about risk factor modification, and mentioned the importance of diet and the importance of controlling blood sugar and cholesterol, et cetera, et cetera. One that I didn't hear mentioned, which in fact was considered one of the most significant of risk factors, and the one that we can most easily try to control, is cigarette smoking.
Mm-hmm. Yeah,
Lowering
yeah.
the cigarette smoking.
Go ahead, Dr. Court. Dr. Atherley, go ahead.
Yes, stopping cigarette smoking can significantly diminish the occurrence of heart attacks. If people smoke cigarettes frequently, you stop cigarette smoking, within 1 year, you may have diminished your risk of a heart attack by 50%. But if you stop smoking for 10 years, then you no longer have any higher risk factor than people who were previously non-smokers. So cigarette smoking is a very important one, and one of the most adjustable of our risk factors, if only we can be disciplined enough to stop the cigarette smoking.
And
Does this also apply to marijuana smoking?
No, I think it does not. Marijuana smoking is not considered a stronger risk factor for coronary artery disease, although we are discovering some kinds of heart disease and other diseases that may be related to excessive marijuana use. And the feeling is that the marijuana nowadays is more potent than it used to be when we did a lot of these studies. It's a more potent strain of marijuana, so
Mhm.
one has to still be very careful. But
Dr. Sprott, your hands up.
Yeah, Trevor, the questions around cholesterol have always been something that I've been interested in. And you talk about the issues in terms of the effect of cholesterol in terms of the coronary arteries and narrowing them. But, there are a number of people that might have elevated cholesterols that have no kind of symptomatology, no evidence of atherosclerotic heart disease. And Dr. Karanam talked about the advances in ultrasound and being able to evaluate the heart. And the other thing that you didn't mention was the cardiac CT that's able to sometimes evaluate whether or not there's narrowing in the coronary arteries or not. And so my question is, if you don't have any sort of complications like hypertension, symptoms, evidence of atherosclerotic heart disease, and non-smoker, never smoked, never had issues in terms of alcohol. How important is it to have a cholesterol that's of a certain level in the absence of all of those things?
it's a good question. I think that the risk factors are summative, and of course your risks increase as you have more and more risk factors. But any one significant risk factor is still considered a risk factor. And there probably are other factors that we cannot easily identify. So if one that we can identify, such as cholesterol, if your cholesterol is severely elevated, the LDL or the bad cholesterol, then it still behoves you to control it at this time, given our state of knowledge. Even though you may have of the other recognizable risks, you may not have significant recognizable risks. Don't forget, a risk that creeps upon us is age. Age itself is a risk factor, and therefore you can't stop the age from progressing once you're alive. So cholesterol plus certain age, and then there are others that may be a little bit more obscure. For example, not obscure, but not as easily recognized. Family history. Other members of the family may have had coronary disease, and that individual patient with the high cholesterol may not be aware of these. So I still think that it is important. It behoves us to control any of the risk factors: hypertension, diabetes, dyslipidemia, or high cholesterol, high LDL cholesterol. So control any of these if they are significantly elevated.
So Trevor, when you talk about that in terms of the risk factors related to family history, a lot of the issues, especially, when I was growing up, almost all of my relatives smoked. They smoked heavily. They all drank. Uh, they didn't do a whole lot of exercise, and a number of them had hypertension. And so, a lot of those sort of family history issues are complicated by those things that those individuals did that hopefully some of the folks from the younger generation didn't have. And so I heard what you said. I just have always been concerned about, cholesterol in and of itself is the backbone chemically of many of the hormones. And so and no one knows how it's regulated or not regulated. And in pediatrics, we used to have people that had hypercholesterolemia where their cholesterols were off the charts in the 400 or 500s or so. And so the issues in terms of when it's around 100 and all, around 200 and all, and we don't know why your body is allowing this to happen. We know that we talk about dietary issues, but very often dietary may not have a strong role in either modifying it up or down. And so what we end up doing is taking statins that are come down, and lots of folks have issues related to statins in terms of muscular or renal or liver and things like that. And I've always been concerned about taking things to lower something when I'm not so sure what it may or may not be doing. And that's sort of a challenge that I have in terms of not taking statins. So there must be other folks like
I can
me.
certainly appreciate the concern about taking any medications, and we've had all the concerns about the side effects that have been mentioned about the statins, of course, reversible. But the point is, this is a disease that can creep upon you slowly, gradually, and severely. If you do not do things that you feel can limit the deposition of cholesterol into those tissues in the coronary arteries, and you wait until you have significant symptoms, or until they've narrowed the artery such that you may have hypertension, or until something else crops up, you may allow a wonderful opportunity to limit your risk for coronary blockages and heart attacks by waiting. So I still feel that if there's one risk factor, that you should try to control that one risk factor, whatever it is.
So what I was hoping you were going to say is that you could sort of look specifically at the coronary arteries to see whether or not there is any narrowing of any of them over time. You know, we talk about for colon cancer, colonoscopies, or we talk about all these kind of things. Seems like there ought to be some kind of recommendations to evaluate the coronary arteries over time to see whether or not there are any gradual decreases in the lumen of those arteries.
Yeah, absolutely. There are some tests. Like we go on to the whole gamut of the non-invasive testing for the heart and all that. But I'm not sure this will give you the security and safety. The whole idea of these tests is if they show something bad, then you go and you start being more aggressive in terms of your further evaluation of the patient. But you're talking about the calcium scoring, which may give you an idea of calcium in the coronary arteries, or even the stress testing, or CAT scans, which are scans of the coronary arteries, the CAT scans of the coronary arteries, which can show you early narrowing. But even in the absence of these, I still contend that in the absence of these, it still behoves us to control the cholesterol to certain levels. So I'm not going to let you off the hook in terms of you're watching your cholesterol, Kendall. I still think you should watch it closely and get it to acceptable levels.
I watch it, but I still refuse to take statins.
All right.
Oh my goodness. Oh, that's great. That's great. All righty. Well, that's one thing we all understand, that physicians are human too. So we all have our opinions, that's for sure, and we're going to do as we need to do. I always say, grown-ups do grown-up things, you know what I mean? And we make those grown-up decisions. So we have to go forward and be comfortable with our decisions. And yeah, I'm just going to leave it there, because there are always interesting decisions and difficult decisions that we have to make, being physicians and talking to our patients and letting our patients make their decisions. So it's so interesting.
I see that Nelson, Dr. Aloha, has joined us, and he's an expert certainly in some of the preventative aspects of cardiac disease. And just on the other side, yes. And can tell us a bit more about the role of hypertension. I always respect his role as to hypertension, some of the racial aspects of hypertension and all that.
Right.
Nelson, how strongly do you advise your patients to control those risk factors that we've identified?
He has his hand up already, Dr.
He's ready. He's ready for us.
Go ahead, Nelson. I knew he was going to jump in.
Well, I mean, like the old saying, prevention is always better than cure, period. And that's the mantra that we need to take. Whether you're a physician, a lawyer, a doctor, a driver, a mechanic, or whatever you are, prevention is always better than cure. And the primary essence of what we do and teach our patients is to take steps to preventing those risk factors or things that put you at risk for those things to take place. So, for instance, if you know there's a strong family history of obesity in the family, then ab initio, you have to take steps ensuring that you exercise, you eat right, you keep your weight down, and everything else. We know that obesity and our diet in this country started way back in the 1970s, when tobacco companies bought the food industry and all that. That's a whole geopolitical issues that came with it. But then obesity went up to peaked, I think, in 2016, and then plateaued. But this year, for the first time, they're saying obesity is dropping here in the United States. It was 40% across the board. Today, it's about 38%. So for the first time, it's dropping. So hopefully that would, spell good things in the future, especially in the Black and brown communities. So, and other risk factors, high blood pressure, like we talked about. Again, strong family history of blood pressure, ensure take steps and to mitigate those things. And I always say in the Black community, if you look around globally, the fastest people on earth, male or female, are Black. There's a reason why. It's not because they exercise more, they train more. It's just the genetics. So we cannot take away genetics from who we are and the things that keep us, make us some of the best or fastest for runners on earth. It gives us that advantage. But the disadvantage is that for black folks or people of color, if you don't move those muscles, then those muscles begin to accumulate, sugar and then fat, and then inflammation becomes the biggest issue because at the end of it all, it's the food, the sedentary lifestyle that predispose us to inflammation. And of course, if you look at us again, vitamin D plays a huge role in who we are as black folks. So if your vitamin D level is low as a black person, it increases your risk for inflammation. And with inflammation sustained, atherosclerosis begin to take place, meaning the narrowing, the damages in the walls of the arteries, they begin to really take place. And that those are some of the things that we in the primary care level begin to teach. So when you come in, check your blood pressure, make sure it's controlled, make sure your weight is stable, um, and not increasing. Make sure your sugars are controlled. And of course, we check again for your vitamin D levels because those things we know are playing huge roles. And then we encourage exercises. A lot of time, I just say do a little something every day, a little stretching when you wake up every day. I give the analogy if you put a bucket in your bathroom and put one drop of water every morning, in 3 months, it will fill up. So it's not the amount that you put in, is the accumulative effect of the one drop every day that shows. So one small exercise every day over time accumulates and makes a difference for you. So these are some of the things we really teach because again, a individual who exercises at least slowly every day, a little, no matter how small, makes the vessels a whole lot more pliable, meaning the walls are a lot more stretchy. I use the word, and they can respond more to your demand. Meaning, if you have to run, if you have to exercise, if you have to do something else, yes, it would, it does because over time, if you don't do that and the vessels get stiff, a lot of people tend to have strokes when sudden events take place. For instance, even at weddings, um, um, great news come up and all that, and that's when those vessels, tend to pop up for high blood pressure. And for those who are infective, those things do happen as well. So on the primary care level, these are the ways we approach these things. And I always talk about technology and applying technology to whatever we do at any day, anytime. In our community, as the world moving forward, we need to know technology, understand technologies, adapt and utilize technology. The one everybody's talking about today is what? AI. How can we use AI on an elemental level for our people? So ChatGPT or Glock or whatever is there, listen, a lot of us as doctors may not have the time to truly use these things or use this thing and teach you how to use it. But you can learn those things because every time you use them, it begins to learn you. That's why they call, machine learning. They learn your pattern, they learn how you think, they learn, the things you need based on what you put in. For instance, I had a patient who used ChatGPT, put all his results in there and say, you know what? Analyze this result like you analyze it for a 14-year-old. And the result, it analyzed it really level at the elemental level for that individual. So he got to understand and learn these things, and then he just got into becoming having Medicare. So he says, "What do I need? I'm going to see my doctor, which is me today. What do I need to use to do before I see my doctor?" Of course, ChatGPT, and I've said these things before. ChatGPT spilled everything else for you. These are the things you need to do, what you need to take with you when you come to, so that by the time you come to the office, it's a very productive encounter where you have questions that are answered and the preventative measures that you need to take care of are already spelled out for you. So even when the doctor forgets, you'll be able to remind your doctor. And that's the engagement that we see. And hopefully that technology will help in our community for us. So we're looking forward to good times and good times. So even as providers and doctors, we too need to learn these technologies because otherwise, if you don't learn this, we become what do you call it?
Obsolete.
Obsolete, yes. And everything that is obsolete becomes irrelevant. And anything that is irrelevant becomes discarded. So we must learn these things as well.
Excellent, excellent. Dr. Sprout, that hand is up one more time. Go ahead, bro.
Yeah, Nelson, you mentioned about the rates of obesity declining for the first time. And once again, I wonder what the impact of all these drugs, Wegovy and
Yes.
everything else are having in that, because, we talk about trying to talk to our patients about trying to change habits, to eat healthier or to exercise more. And folks just want a quick fix.
Hmm.
And I don't know if we know the long-term effects of some of these drugs that are causing people to lose weight without necessarily having to change their dietary habits and
Hmm.
everything else. So, Omar, you're a nutritionist and you talk about but I do believe that people are jumping on the bandwagon, and more people that aren't even obese are taking these drugs in order to get more muscular or to
Hmm.
have less percent of body fat. It's getting out of hand.
Well, let me just say, Nelson, I want to let you take this in a minute, but I just and those of you that know Dr. Cynthia Page, um, I connected with her. She had an excellent article on LinkedIn about the GLP-1s and patients losing weight via the GLP-1s. But the interesting thing is that they're losing fat, but they're losing their lean body mass as well. And that's one of the things that's not been talked about at this particular point, where your weight is coming down, you're losing a lot of fat, but you're losing that stimulus that maintains our organs, our muscles, our internal organs. You're losing that as well. So that's something that I think may be coming out in the future as far as these medications are concerned. Go and actually we're going to have her on the show pretty soon, coming up first part of the year, just to let you know. Dr. Page, who was the past president of New Jersey Medical Association. So that's all good. We're looking forward to having her. Nelson, go ahead, please.
Yeah, so yes, the GLP-1s are doing that. And this now they're looking up to seeing if they can have Medicare, Medicaid pay for the GLP-1s.
Mm-hmm.
Um, what are the advantages? The advantages. Look, in everything, there's always an advantage and there's bad outcomes. I always say that for every good thing, there are bad outcomes. For every bad things, there are good outcomes. So it's a measure, and that's why in medicine we talk about risk versus benefit. You understand? Even
Mm-hmm.
when we talk of vaccines, yes, vaccines has done a whole lot for everybody and for the entire world. But there are people where, they've come out the short end of the stick out of it. There's no
Mm-hmm.
doubt about that. And that's with everything else. So with, the GLP-1s, um, reducing obesity on a global, national scale for overall health. What's the advantage? Yes, a lot of people will lose the weight. Yes, the risk of obesity, diabetes and obesity will decrease. Yes, hopefully the risk of kidney disease and cardiovascular disease and all that will reduce. Yes, a whole lot of all these things will reduce. Um, on a national level, it may look good on the US data on spending 18% of the GDP on healthcare without bad outcomes. So maybe this, on the long run, would show that finally something is happening. The 18% of the money we're spending is helping. And would it be disproportionately better for some communities? Maybe more for the Black and brown communities, yes. Um, but then there are other things that are coming up that we will see and that we don't know yet.
Mm-hmm.
There are reports of visual problems and eye problems with the GLP-1 use. We now know that if you're going for surgery, you can't use the GLP-1s. You have to stop it for a short while. The rapid weight loss outcomes of it, and then the weight loss, body mass and body lean mass and all that. what else is happening in our brains? You understand? If we're losing fat, there's a whole lot of fat in the brain. Would we see in the long run that Alzheimer's will increase, or would we see that a new form of memory issues will begin to come up? We don't know that yet. So a lot
Mhm.
of things will show up as we begin to keep an eye and look at things. But the immediate gratification of weight loss, reducing diabetes and all that, yes, we'll see. We'll continue to pay attention and educate ourselves, inform ourselves so that we can better educate our communities.
Mhm. Yeah, yeah,
Omar,
definitely.
Omar, I don't see a large number of obese patients, but the ones I see, what I've noticed is the glucagon analogs, when you use them, it gives them a starting point. At least they begin to see that they're losing weight. It's easier to convince them to do the step two, step three. Some of these people can't even get off that first pound, no matter how much they quote try.
Hmm.
As long as I've known the GLP-1 drugs, they always recommended exercise along with that, knowing that lean muscle mass goes down. So you have to promote losing the fat but maintain muscle mass by exercising. That's again a compliance issue, but
Right.
this at least gives them the first push
Hmm.
for them to do the next step. They feel good about it. Okay, maybe I should do it, type of thing.
Hmm. Hmm. All righty. You know, Ravi, I just wanted to get back to you, um, and just a few questions. How, after cardiac surgery, how long you expected your patients to be in the ICU, as far as recovery is concerned?
A routine cardiac surgery, which is a coronary artery bypass or valve replacement repair, something like that, in somebody with not multiple comorbidities, they generally go home fourth day after surgery.
Mm-hmm.
And they go home, they're able to walk, shower, shave, get dressed, and
Mm-hmm.
do routine daily activities. We don't allow them to drive for 6 weeks.
Mm-hmm.
External stability is important, and if they don't have a power steering, they can suddenly get the catch when they're turning the steering wheel, things like that. So 6 weeks we make them not drive or lift significant weights. But usually by about 6 months they forget that they had surgery. Life
Mm-hmm.
is normal, except when the weather gets bad, it hurts like a joint pain, like an
Mm-hmm.
arthritis, reminding
Right.
them they did have heart surgery for a couple more years. But usual hospital stay is about 4 days.
Hmm. What about post-surgical cardiac rehab? Is that a part of something
Yes,
emphasized?
we routinely recommend that they get cardiac rehab, which is mainly walking. Most of the recent studies show, even for average people, walking is the best exercise,
Hmm.
cheapest exercise, the lowest risk exercise. So if everybody can walk a couple of miles a day, life would be great. But that's one thing we recommend: walking a lot and sort of stretch exercises like the shoulder exercises, low impact mainly to keep. One of the things some of these people do is when the chest hurts, they begin to walk hunched over.
Hmm.
That's not good. After a while, they can't change their posture. So we try to make sure that they walk straight, stand
Hmm.
straight, walk tall, like a
Hmm.
soldier. I say them, walk like a soldier, not like an old man. So, so they basically walking and they sort of coughing, clearing their lungs and all of that. That's the kind of stuff. Nothing really uh, phenomenal until about 6 months to a year when they're physically completely fit. The
Hmm.
cardiologist may increase their activity level, but mainly walking and range
Hmm.
of motion exercises.
Okay, all righty. Dr. Luya, your hands up, please.
Yes. So, thank you so much, Dr. Karadam. It's good to see you here.
My pleasure.
I mean, you've been in this cardiothoracic space for forever. So if you were in the military, you'd be a field marshal by now. So I really appreciate what you've done. I've seen your work and all this over the years. And
Thank you.
but my question is, as you've seen from probably the last 20, 30 years in your career, as cardiothoracic surgery, and medicine changes in itself. The change is even here as well. Technology is changing a whole lot of things, and as we see, and as somebody who still deal with young people and still encourage young men and women into medicine. What is in your thoughts and your mind? Uh, would cardiothoracic surgery look at as in the future in the face of emerging technologies?
Okay. Well, cardiothoracic surgery has gone through substantial change. A lot of it, I think, is good because we had our answer for all the problems was a big operation once upon a time. Progressively, we've decreased the uh, size of the operations as much as possible, um, and also less invasive operations if possible. And also, there are structural cardiologists and the interventional cardiologists can buy more time before we put him through a big operation with its risk. So there's a lot of these things change magnitude and when do you actually interfere and all that surgically. Those things have changed. But one thing that you all know, I don't have to tell you, the coronary artery disease mortality has decreased substantially over the years. At the same time, heart failure mortality has gone up exactly same amount.
Mm.
So what we're doing is bringing these people further along, and now they heart is burnt out. They have heart failure as the main problem. So now we are putting devices and transplanting. Now the mortality and morbidity is almost equaling transplant. With improvement in the devices, we are able to postpone the transplant because the organs are in short supply. You never have enough organs. There are 300,000 recipients, 3,000 hearts available in the country. So more and more people are getting the devices. As we're putting more devices, they are also getting miniaturized and results are getting better. If they survive the operation and go home, their 5 year survival is no different than heart transplant at this time. So once we can externalize the power source with no wires sticking out, transcutaneous induction and all that, probably the devices will last longer. And what we see in the near horizon is by a 10-year survival may actually equal the heart transplant.
Mm.
So those are the good things. And then bioengineered organs are coming up. So far we put in man-made valves. Their longevity is 10, 15, 17 years. But then again, we have to do something. That's where the valve-in-valve TAVR fits. But that also has a limitation. So when the bioengineered human valve, genetically engineered, come up, surgery will again increase because they will have substantial longevity than any valves that we do. So
Mhm.
I think then heart surgery will get another spike.
Mhm.
So
Mhm.
that's what I foresee uh, in
Do,
heart.
do you, Robbie, do you think you said I think you said heart failure or cardiomyopathy? I think you said heart failure increases and coronary artery disease is decreasing. I think that's what you stated.
Now, the coronary artery disease mortality has gone down.
Mortality. Okay, but
Yes.
do you think that's because we're living longer?
No,
Do you think?
I think that's because of what Dr. Atherley does. They
Mm-hmm.
have to rush in the middle of the night, mile a minute to door to blush 45 minutes. That's not easy feat to do. And
Mm-hmm.
they do that. And now that's even being pawned out to EMS. Now, the
Mm-hmm.
EMS people can actually begin to administer medications on the scene and take them directly to the cath lab, not to the ER. So
Mm-hmm.
eliminate that delay. So as the delay in intervention decreases, it did two things. You prevented a lot of heart attacks and the consequences thereof. In
Right.
addition, if they did need an operation or something, the patients I got are much better shape, not with an acute infarct. Their mortality was very high after
Mm-hmm.
following heart attack. They abort the heart attack so successfully. The aspirin beta blockers, early intervention have
Right.
definitely changed the outcomes of coronary artery disease.
Mm-hmm.
Because of that, heart attack deaths have decreased overall in the country. But if
Mm-hmm.
you look at the other half of it, heart failure deaths have increased in the same proportion, where people are living longer
Living longer.
after all these interventions and they're reaching the heart failure age, but they're
Mm-hmm.
not transplant age anymore.
Right.
So then you have to put devices in them. Okay.
Mm-hmm.
Whether the device are going to bankrupt the country or not, we don't know. They're very expensive, but they do work.
Excellent, excellent. All righty. You know, the thing of it is that we're just about out of time. Actually, we are out of time. But I just want, Ravi, I'm going to go through a few things, and then at the end, I'd just like you to sum up what you think, how we should sum up these 2 hours, because it's been fantastic.
Okay.
You know, I just want to key on several things because we've covered so much today, and so just as far as how to strengthen the weaker heart, you know, follow up with your doctor. Number one, number two, and number three, you should follow up with your internist. You have a cardiologist that you follow. Please follow up with that person. Exercise regularly. It doesn't have to be intense exercise like Ravi stated, and I think Nelson stated as well. Walking, swimming are probably the two best exercises that you can come about. You know, adapt a healthy diet. So what we want to do is eat more of a balanced diet, limit the sugars as far as the salt is concerned as well, and vegetables and fruits, very, very important as well. Limit the fried foods. Um, as we're talking about that cholesterol, alrighty. Manage other health conditions, as I stated, cholesterol, and manage your blood pressure, and definitely keep an eye on your blood sugar. Make lifestyle adjustments, things like quitting smoking and avoiding secondhand smoke. And it's real. Secondhand smoke is real. You wouldn't think so, but it does affect the person if they're around a smoker that's 24 hours a day. Limit your alcohol and your caffeine. Maintain a healthy weight. And these are some of the things. And get appropriate sleep. And the final thing I will say is decrease your stress. I see. So you can't imagine what stress will do to you as far as your body is concerned. You got to decrease your stress. So next week I'm going on vacation and I'm going to decrease my stress for a whole week, just to let everyone know. All righty. So, Robbie, what I'd like you to do is just sum up for us. Or not even sum up, but just tell us what you think is important from your specialty and your perspective.
Yeah. Cardiothoracic surgery is a very exciting field for me. We take sick patients and sort of put him through major operations, nurse him through for success. That said, I think the goal for all the doctors and patients is to stay away from the heart surgeons as much as possible by doing prevention. An ounce of prevention is pound of cure. So, and prevention is not something you can just talk about it. It has to start from when you're very young. Kids do what parents do, not what they say. So, but lead by example, educate them very early how eating balanced diet, staying active, and avoiding bad habits are very important for a longevity.
Mhm.
If you do none of them, you may even live longer with a tremendous amount of health care that we provide, but not a quality of life. So you want to accomplish longevity and a quality of life. So try to do everything that possible that you can prevent bad things from happening by exercise, eating right, avoiding bad habits like smoking and drugs. That also saves a lot of money, actually. Smoking is very expensive. I don't know if people realize or not. I
Mhm.
tell many of my patients when they smoke, they could probably pay off their mortgage if they calculate how much money they spent on smoking. And the other thing is regular checkups. And try to learn a little bit about your family, despite what like Kendall said about mitigating factors that made them look like they had risk factors. Just learn a little bit and s- pay special attention to factors that cause damage to you because of genetic factors. You can't choose your parents. It's
Mhm.
like somebody said to me one time, genes are like loaded gun. You can avoid pulling the trigger by recognizing and go to your doctors and have early checkups for all the possible illnesses that can come to you, and put it off as long as you can. There is no immortality. We all have to die someday, but the key is to live healthy as long as we can live.
Mhm.
Longevity and health are very important. That is accomplished by prevention and checkups.
Excellent, excellent, great. I think that's just the greatest advice you could give, Robbie. It's not fancy. It's just basics, and it's all about living long, but living long healthy, and that's so important. All righty. In closing remarks here, I would like to thank OB Healthy for allowing us to bring the Doctor's Lounge to you. Without them, believe me, we just couldn't do this. This is every second Saturday, please. And I always say it takes a village. You got to tell people about it. You got to let your friends, your church members, even your enemies, let them know that they can get great help as far as medical advice here at the Doctor's Lounge. Okay, we're here every second Saturday at 1 o'clock. All righty. And all you have to do is go to OB Healthy and click the doctor's tab and come on in and, ask your medical question. That's the most important thing. Don't be too shy to type in your medical question. All right. The most important thing I can say today is please do not change any aspects of your medical care before you consult your physician. Only your doctor, truly, only your doctor can best take care of you from a medical perspective. If you missed this past webinars, or if you want to see our past webinars, all you have to do is go to our YouTube channel, and you can get that through the webpage, and all of them there. And please subscribe when you come to YouTube, because so we can continue to bring that link to you. All right. I look forward to seeing you next month, definitely. And all I can say is at this particular point, just spread the word, about OB Healthy and the Doctor's Lounge. All right. So until next month, I want to say thank you to each and every one of the physicians that came on today. Robbie, I just can't thank you enough for coming in and educating us about cardiothoracic surgery. And all I got to say is peace out, everybody. Until
Thank you.
next month, we'll be here. Peace.
Thanks, it's my pleasure. Thank you.
All
All right.
righty. Take care,
Bye-bye.
everyone.
Bye,
Bye-bye.
everybody.